Welcome to today's episode of the Medical Fitness Podcast, powered by the Medical Fitness Association and MRF Institute. My name is Thomas Hammett, and I'm the Director of Operations for Pinnacle Lifestyle Medicine and a co-founder of the Medicine Rehab and Fitness Institute. My co-host today will be Jeff Young, kinesiologist and also co-founder of the Medicine Rehab and Fitness Institute. Morning, Jeff.
Hey, everyone. We are excited to have Simon Matthews as a guest on our show. Among many other things, Simon is an expert in health behavior change coaching, which is what we're excited to discuss today. Welcome, Simon. Could you get things started by introducing yourself and your professional background?
Yeah, of course. Thank you, Jeff. Thank you, Thomas. Professionally, I'm a psychologist and have been for nearly 30 years, I guess. And at some stage during my psychological career, I got interested in particularly health and supporting people, not just with mental health, but physical health as well. That's when I started realizing and recognizing the connection between diet, exercise, activity, health and well-being generally. And that's what led me into lifestyle medicine. That then tipped me into, of course, being a psychologist, the area of behavioral change and health coaching. And these days, that area of coaching is the area that I tend to inhabit, both as an educator and a supervisor and a mentor for trainee coaches, and also as a coach, particularly to healthcare leaders.
Hey, I just noticed on LinkedIn your post today about your presentation at the ACLM conference in November. Do
Yeah.
a real quick plug for that. And what's that all about?
Yeah, sure. Thanks, Jeff. So essentially, my it's a pre-conference workshop, and it's intended for any sort of healthcare clinician who has experience of working with patients who experience hopelessness and helplessness about change, which is a lot of people, at least some of the time. And one of the really challenging aspects of that is that encountering hopelessness and helplessness in another person often leads to a kind of I'll describe it almost as a parallel process where the practitioner or the clinician can end up feeling de-skilled, demotivated, and over time, if that becomes chronic, they start to lose interest even in their work, and now they're on the road to potentially burnout as well. So it is a particular challenge working with patients who are experiencing hopelessness and helplessness. The good news is that there are effective ways that we can manage it, which both support the patient to start connecting again with some different ideas of their own and some different skills and resources of their own. And those same ways help us as clinicians to what do I say here? Keep our own professional composure about that, and not fall into that pathway of starting to burn out.
Yeah, great topic, important topic, and I hope it's a packed house for you. But just don't be stealing any of the participants who should be coming to our pre-conference presentation. So
Yeah,
that's great.
I think we're on opposite each other, but
Yeah.
yeah. Okay.
All right, I'm going to kick things off with a question that was actually prompted by um, I can't remember if it was a DM that we had through LinkedIn or one of your LinkedIn posts, but you had mentioned something called the common factors theory. And so, so I'd like to start off by asking, can you explain what the common factors theory is and how it applies to behavior change beyond psychotherapy, specifically in the clinical and medical fitness settings?
Yeah, absolutely. Absolutely. So first of all, common factors theory has been around for a lot of years now, and its origin, you rightly pointed out, is in therapy, and it emerged in the sort of middle part of the 20th century when there were already a lot of different therapy types around, and people rightly started asking the question, well, which one of these is the most effective? And so some clever researchers got together and started examining this, and the answer surprised them. and the answer was that all of those different therapy approaches were about as effective as each other, and that didn't matter so much as some other things. So the common factors research really turned up four major factors as predictors of behavioural change. The first is the client's own skills and resources. The second is what we call the therapeutic alliance, or the coaching alliance, or the clinician-patient relationship. The third is the capacity of the clinician to support the development of hope and expectancy in the patient. And that fourth one is actually the particular tool that you use. So in a coaching and behavioural change in healthcare context, then we might think about things like motivational interviewing as one of those tools. So if we contextualize that further, what that means is, yes, you absolutely need some tools like motivational interviewing, but motivational interviewing doesn't do the heavy lifting here. What does the heavy lifting is your capacity as a clinician to support your patient to recognise and harness their own strengths, their own resources, their learnings, their supports, and/or develop more of them. And secondly, your capacity to create and develop a warm, engaging, compassionate, empathetic relationship with that person. And if you can do those two things, you're well along the path towards being able to support someone in behavioural change.
Yeah, I'm really resisting asking you to just tell us what your entire course is going to be at the ACLM, because I think that's kind of the road that we might start going down. You were just talking about the hopelessness and helplessness that patients present to clinicians and medical fitness professionals with, and certainly that can lead the professional down the road of feeling the same way when they don't see the change that they expect out of themselves. I talk to physical therapists about this a lot, that the medical system expects us to fix our patients' issues, and when we don't see that result as expected, we start to put that feeling on ourselves, not recognizing that there's a bigger context of the patient's life and situation going on, and that we need to be zooming out a little bit and focusing on the person and helping support the person and not just fix their issue, right? So I want to start talking about that practitioner and client relationship, because I think you had mentioned something about that that's important here. It was the second point you mentioned of the four things that you had just talked about in common factors theory, and I'd like to get a little deeper in that. So what specific clinician behaviors or communication strategies make the relationship more effective in supporting change?
Yeah, wow. That is a great question, which has a complex answer. But let's start digging in. So the first, I'm going to say the first parts of it are deliberate intentionality on the part of the clinician. So it's important for all of us as clinicians that we spend some time thinking about how do I want to be in this particular relationship that I have with this patient? How do I want that person to perceive me and experience me? And most of us, of course, would arrive at something like, well, I want to be perceived as caring and kind and supportive and encouraging and words like that. So that gives us some clue straight up about some of the behaviours that we need to bring with us to those relationships. There's some other things as well, though. An intention to be collaborative, I think, is really important here. An intention to not bombard the person with expertise, our own expertise. And that's a challenge for a lot of clinicians. When I went to university and studied psychology back in the 1990s, I left my degree program with really four pieces of knowledge, the 4Ds: disease, disorder, dysfunction, and diagnosis. They were the four things I was really good at. And that whole education system, I think, also encourages us to believe that the very best thing that we can give our patients is all that knowledge we spent 4 or 5 or 6 years accumulating. And in fact, the very best thing that we can give our patients is interested, focused, intentional, compassionate attention. And if you can do that, then, like I said, you're well on the way to creating the sort of conditions that are going to support someone to be able to engage in change. And I'd love to tell you about a couple of really interesting research studies in this area. Actually, they go one goes back about 14 years, and this was a piece of research about patients who had high cholesterol and patients who had diabetes. The very short version of the study is that a group of physicians were assessed using a well-established scale of empathy. It's called the Jefferson Scale of Empathy. They were assessed on their capacity to show empathy. And of course, as you would expect, different physicians came in at different levels. Then the patients who met with those physicians were tracked. And the really interesting finding from that study was that the patients who were working with physicians who scored high on empathy at the end of the study appeared to have the best level of control over their HbA1c and their LDL-C. So that's kind of curious when you first hear it. You think, wow, okay, so there's doctors being empathetic and these patients who seem to do better. What's going on there? Well, let me tell you about the second study, which was actually published during the pandemic. This study came from the UK, not health related at all. It was done inside the justice system, and it had some similarities. So prison officers, prison wardens were put through an empathy training course, or a group of them was. And then the inmates assigned to those prison officers were tracked over time. And one of the findings, among several, was that the prisoners who were kind of assigned to the wardens who had been through the empathy training ended up having lower rates of recidivism. They were less likely to return to their criminal ways. In other words, there's a behavioural change there. We've seen a change in their behaviour. So what's going on? We've got empathy on the one hand and behavioural change on the other. What's the mechanism that might explain that? And I wouldn't want to say that this is the mechanism, but my hunch is that the mechanism here is that when we're engaged in a professional relationship in which we feel like another person is interested in us, values us, wants to understand us, is curious about us, we know that they want to support us, there's a sense in which starting to experiment with different behaviours that we might feel uncertain about feels a little more okay. It's almost like, if I were to pick a metaphor, it's almost like knowing that there's a life ring hanging on the wall close by, and if you get into trouble, you have a sense that there'll be someone there to support you. So, like I said, I'm not certain that is the mechanism, but I've got a hunch that that's at least in part what's going on. And so this idea of therapeutic alliance or coaching alliance or simply the clinician patient relationship is ideally characterized by a positive regard, a looking at the other person and recognizing immediately not the illness or the disease or the incapacity, but the skills they have, the resources they have, the internal strength they have to be able to move forward. It's characterized by displays of empathy, by displays of curiosity, by showing interest in the other person, by reflecting the small steps of progress that person is making, no matter how insignificant they may seem. by recognizing and affirming the values or the beliefs or the capacities that that person has, the choice to be able to move forward. And if we can invest ourselves in constructing relationships like that, then I think that really starts to cover off most of that idea of coaching alliance or clinician-patient relationship.
Well, you very much delivered on what you had promised, which is that this is a big thing, right? As you were talking, there were a couple of things that came to mind. I have a question I want to ask you, because I think the idea that therapeutic alliance is pretty well known, particularly in the physical therapy world. But I know it's just generally speaking well known now that there is some link between the therapeutic alliance and a medical, let's call them a patient, or the person seeking care, their outcome. But one of the things that I was thinking about as you were talking, I couldn't help but my mind go to any movie where there's a sports team and a coach, and uh I think of like Hoosiers and Coach Carter and any classic sports movie where the coach comes in and you don't see them do any sports specific coaching of note, right? It's not like the movie Hoosiers is about good basketball, but it's about the way that that coach interacts with the people, and certainly sets boundaries with themselves and the others around them, but also communicates with compassion and care and shows people their potential. Which is why I love sports movies for this purpose of helping people see the potential of themselves in these roles. We don't often think of ourselves as coaches in the way that coaches of youth athletes are. But it's a very similar role when people come to seek our support, and we have the option to play that role. So I couldn't help but my mind go to that place, thinking about all the things you're describing are these effective people at supporting others see their potential and work with either that coach or the people around them to be successful in ways that it's not like they're telling them what to do, but they're supporting their own belief in themselves and ability to make a meaningful impact in the world. And but I want to go back. I wanted to say that real quick because it's where my mind went. But I want to go back because I think there is a lot of confusion about the therapeutic alliance. And I wonder if you could talk a little bit more about what that looks like in practice. And maybe what I'll start by saying is I think when I see it go wrong, it looks like the idea is that we try to be friends with our patients or clients. And I think there may be a misconception that the therapeutic alliance is, well, if I'm good friends with my client, then I'll get the outcome that I'm seeking. And I don't think that's what you're saying. So I'd love if maybe you could contrast the two between what the reality is and what that being friends kind of relationship is.
Yeah, that's a great question, Thomas. The first thing that I would say is that in a professional relationship, as distinct from a friendship, our primary duty, and this is generally inscribed in all of our respective codes of ethics, our primary duty is to the client or the patient. And that's made clear to us. Our work is in the service of the benefit of that other person. Not so in a friendship. In a friendship, we kind of want and expect, I guess, that we're all getting something out of that relationship. And yes, it's true that professionally I personally derive satisfaction from the work that I do. I enjoy the work that I do. So yes, I'm getting something out of it, but I'm not doing it with the intention of simply trying to be satisfied. I'm doing it because I've got a fundamental belief that the person I'm working with is important, and I've essentially taken an oath of sorts with my code of ethics to make sure that I'm providing a service to those people. The second thing that I would say is that, and this kind of builds on the first, I suppose, that there's not a mutuality in the professional relationship. Every so often, grateful clients or grateful patients will bring a gift or something like that, or they'll express gratitude to us for the work that we've done with them. That mutuality is much more present in friendships, much less present in professional relationships, and our response to that, I think, is and needs to be quite different in a professional relationship. So, for example, one of the if I'm teaching practitioners about the therapeutic alliance and things like that, one of the things I often encourage is this idea of being professionally humble. Now, that doesn't mean you pretend you're not as good as you are, or pretend you don't have the skills you have. Absolutely, if you've got great skills, then that's a great thing to recognise and be grateful for. One of the frameworks that I encourage in people is, any time a patient or client comes to you and says, "Hey Jeff, hey Thomas, hey Simon, I just really want to say thanks for what you've done. You've really helped me do this, or you've supported me do that." First of all, acknowledge that, of course, and appreciate the person. Step two, though, is the really important one. Step two is ask yourself, what have I learned as a result of my professional relationship with you? How am I different? How am I better as a result of my professional relationship with you? And that helps us to stay away from that kind of polarized expert and learner idea, which is still quite prevalent in professional health relationships, and recognize that the value that we bring, again, is not necessarily just our subject matter expertise. Our subject matter expertise matters, of course. I don't want to make it sound like anyone can do this, and it doesn't matter whether you know anything or not. Of course, it matters. So whether you're a physician or an exercise physiologist or dietitian, whatever you are, that subject expertise matters. It's just that we don't have to kind of lead with that all the time and sort of push that towards the patient or client all the time. So a lot of that difference between, for me, a lot of that difference between friendship and professional relationship, again, comes down to intentionality, comes down to how I think about this, how clearly I'm guided by my professional code of ethics, how much I maintain that focus on doing what I do in the best interests of the client primarily, and anything else after that is, a pleasant byproduct. But my primary driver is doing something that benefits you.
As I listen to all this, and my mind's just going a million miles an hour right now, and the topic here is health behavior change, and we always think about it from the patient or the client standpoint, and the fact that we want them to change behavior, adjust behavior so they can be healthier. But right now we're talking about the clinician, and we're talking about you're basically describing a skill set. And uh, when I think about my own, in my profession, and going through academia and stuff, we didn't learn this stuff. We didn't learn coaching skills, right?
Yeah.
And I think a couple things that went through my mind that I don't know if it's even possible to answer them or to answer them clearly was, I think some of it is the clinician or the coach, whatever, if they're a clinician or not, needs to recognize that they either have or they don't have the skill set, or that the skill set could be improved. So how can that be something that that is more prevalent in, maybe it has to start in academia and courses or something like that, but to be able to recognize whether or not you even have the skill set, and then let's say
Mm.
someone doesn't, or it's something that could be significantly improved, and they're a clinician, and the
Yeah.
skill set of being able to coach properly, all the things you've been describing with their in that patient client interaction. Because A, it needs to start with recognition if you're not there, and B, is then this a skill set that can be significantly improved. um And I would imagine that the answer to that is yes, and that at least in part, they need to be attending your conferences, I'm sorry, your workshops at the ACLM, et cetera. But hopefully I worded my question well. I'm just curious your response to all this.
Yeah. Jeff, I think your observation about the absence of these skills from basic training for all of us. So even as a psychologist, I didn't learn these skills. I learnt them subsequently to my psychology training. That they, I think it's true to say that currently they are still largely absent from curricula at universities. Uh, I think we're perhaps starting to see the tide turning. For example, there are now a number of universities and colleges that are introducing lifestyle medicine courses, and lifestyle medicine, of course, is interwoven with behavioural change. So that means at that undergraduate level, people at least are starting to get some exposure to these ideas. That still, I think, sits a long way short of developing the skills to be able to do it. So we need to do more. I'm hopeful that what's this 2025? Maybe in 20 years' time, 2045. Maybe if we could have that conversation in 20 years' time, we'd look back and say, wow, look, all these schools and colleges are now introducing this as part of the primary curriculum, which would be wonderful. The second part of it is that all of us, and this is true about anything, all of us need to be honest with ourselves about skills that we do have, and also skills that we don't have. And that's not, I mean, conceptually, that's not a difficult thing to do. If you're walking down the street and you see, like heavy trucks and buses driving past, it's not hard to be able to look there and say, well, okay, well, that's not a skill I have. Yeah, maybe I can drive a car, but driving one of those things, that's not a skill I have. We can be honest with ourselves about that. Being honest that we perhaps could do more to develop our skills of connection and empathy and compassion, I think maybe is, I think it's probably a little bit personally challenging, because most people like to think of themselves as nice people. We we like to think of ourselves as people who are, warm, engaging, interested, and so on. And at the same time, we can fall into lots of common language traps. We can fall into lots of thinking traps that ultimately become unhelpful to people trying to engage in behaviour change. And that, of course, means that we then need to open the door to being able to seek those skills and learn those skills. The really good news, or I think it's good news, is that the skills of health behavioural change, I don't think are rocket science. Yes, they're a discrete skill set, and yes, they cross over with some other things. And like any skill set, there are some people in the world who just seem to naturally embody these skills and display them without much effort. And there are other people who really have to work very, very hard to.
I really appreciate this, and I'm going to use it as a way to lead into the next question. But before I do, I just want to say that I can't remember if you actually said the word or not, but you're definitely alluding several times to the importance of reflection and the
Yeah.
fact that we just need to reflect. And I just wish that, like in life, maybe even if it was this is probably kind of goofy, but like put it in our an alarm on our phone calendar that once every quarter we just have one day where we just stop and just use it as like a reflection day on ourselves, on our profession, etc. And then another thing that you alluded to, or maybe even said a little bit more directly, was the fact that you need to practice this stuff in order to become better at your skill set as well.
Yeah,
And I feel
absolutely.
like in
Yeah.
in my 30 years and the clinicians and look, I'm pointing fingers back at myself too, because I'm definitely guilty as charged when it comes to uh too much thinking that I'm the subject matter expert and I need to hit you with that, and all that stuff. So guilty is charged. But I also have definitely worked with clinicians and actually just professionals in general who were open to admit that uh, this is a skill set that they didn't feel comfortable with, and then to know actually how to get better at it. Um, Part of it is just being able to practice it, as well. But let me use this to lead in my next
Exactly.
question.
Yeah.
Is you've emphasized using a client's pre-existing strengths and resources in some of the things you've been talking about. So what are some
Mm.
practical ways that clinicians can help patients recognize and leverage these assets when it comes to building exercise habits?
The Medical Fitness Podcast is brought to you in part by the Medical Fitness Association. Are you a professional in the medical fitness industry? As a member of the Medical Fitness Association, you'll unlock exclusive networking opportunities with top experts in the field. Access cutting-edge education to stay ahead of industry trends and best practices. Don't miss out on the chance to advance your career. Join the Medical Fitness Association today. Visit medicalfitness.org to become a member. That's medicalfitness.org.
Yeah, wonderful question. Wonderful question. So the skills and resources, of course, they're that main factor in common factors theory. This has a huge influence on outcomes that a person experiences. The most reliable and robust method I know for engaging with this particular idea is to put yourself in a place of not knowing and to ask the patient or the client. The ways that I might do that could be, for example, Jeff, if you came to me, or Thomas, you came to me and said, I really I really want to get fit. I'm just I don't know. I'm just not performing the way that I want to, and I'm tired and sluggish through the day. I really want to improve my fitness. The first thing I would do is acknowledge that, and say, okay, so you've got a real commitment to your own future health and well-being here. So now I'm affirming you straight away. So that's important. This contributes to our connection, our relationship, our alliance. The next thing I'm going to do is ask you, out of a deep sense of curiosity, to share with me something in your life, either currently or in the past, where your health and well-being has taken front seat and you feel like you've managed it really well. And I don't care how small it is. I don't care how long ago it is. I want to give you an opportunity to share with me what that is. You might say, well, back when I was at college, I did this, and this, or last year I did this, or actually at the moment I'm probably the fittest I've ever been. It's just not very fit. Whatever you share with me, then I'm going to be curious with you about essentially, how did you make that happen? Whatever that was, whether it was last year, last decade, whatever, how did you make that happen? And this is where I'm going to start listening really closely, because you're probably, and I'm basing this on lots of conversational experience, you're probably going to give me a whole lot of structural reasons why that was. Back then I had more time, and I didn't have kids, and I lived somewhere where it was easy to run or to cycle or whatever. Okay. But what made you choose to do that back then? So I'm still kind of wanting to focus in on you and your skills and your capacities. And this is the beginning of starting now to explore all this in more detail. And ultimately, what I want to be able to do is to hear you name some of those things to me. When I really want something, I can be pretty determined. Or I'm actually pretty good at planning and tracking things, or I'm a good problem solver, or I'm really driven by a desire to be a good role model for my kids, um, or my wife works long hours as a nurse, and so I really want to be able to be the best that I can to be able to support our family well, or something like that. All of these, I mean, this becomes an unfolding conversation over time, of course. But in all of these things, I'm starting to learn about you and about the resources you have, the skills you have, the abilities you have, the learnings that you've made in the past, the people you have in your life who support you. And this is, broadly this kind of collection of patient skills, tools, and resources that you can now put to use in service of, whatever it is that you might choose to do. And for me, that's an important conversation to start very early in a professional relationship. And it's an important conversation to continue affirming and to continue revisiting as well. Because, as we all know, skills and abilities are not static, they're dynamic. If you can drive a car, there was a time when you couldn't drive a car. If you can be a physical therapist, there was a time when you couldn't be a physical therapist, and so on. So it's important that we stay connected to and keep giving our patients and clients opportunities to share this developing pool of skills and resources they have. And this provides us, I think, with a really interesting perspective on behavioural change and overcoming obstacles and problems generally. And that is that we don't, I think ultimately we don't solve problems. We don't fix problems. What we do is we grow internally. We develop our own skills and resources and capacities internally. And as a consequence of our growth, the size of that problem or challenge diminishes. It feels different. It feels smaller. We see it in a different way. So we don't, strictly speaking, I think we don't go and actually fix or solve anything. What we do is become more complex, more adapted, more utilitarian versions of ourselves that we can get better and better and better at doing a number of things.
I'll chime in real quick and say that, here I am with two people on the show who are much better than me when it comes to having expertise in this and health behavior change. And again, as you're talking, a lot of things are going through my mind. And one of the things from my own perspective, and probably a lot of people who are in my position where you don't feel real strong when it comes to having these conversations, etc. All this stuff is really helpful because I think to myself, it would have been helpful if someone would have sat me down years ago and said a lot of things that you just said, and basically said to me, you don't have to feel going into a conversation like it's your job to fix someone, to find the final solution. So don't worry about that. But it would also help me if someone would have sat me down and along with that said, but here are the outcomes that you're looking for, and here's how you get to those through your questioning and stuff like that. I actually even had an analogy going through my mind, almost of like climbing a ladder onto a springboard, like a high dive to jump in the pool, and that the ladder that you're climbing is those initial questions, just to try to get the client or the patient
Yeah,
to reflect and to think about things. And so you're climbing that ladder, and then you get up to the springboard, and ultimately you want to jump off that, the springboard, because you're trying to
yeah,
get them to springboard to the answers that kind of to saying the things and developing the trust with you based
yeah,
on, oh, this person's
yeah,
really curious, and
yeah.
they're coming from a compassionate and empathetic place. And so I'm more willing to be open with them and candid, and that seems to me like that's a huge part of the goal here, is to develop that trust, develop it quickly, but develop it sincerely and
Sincerely.
honestly
Exactly right. Exactly
sincere.
right.
And then you get
Yeah.
to the end, and now you can springboard them, and because ultimately it's going to come down to you mentioned barriers, and and bottlenecks. And so you're going to have to address those with at least some sort of solution, not necessarily to fix the person right there, but at least to start to move them forward in the process over time of behavior change that is dynamic. If people would have sat me down years ago and explained it, at least in some sense, I'd have been like, okay, all right,
Yeah,
I think I can do this. And then also understanding that as a coach, this is something I need to practice over time. I'm not going to be a master at it. And just like it's a
absolutely.
learning curve. And if someone would have
Yeah,
told me that too, don't worry about it. You're going to have to practice it over time, and you'll get better and better as you practice with more uh in my case clients, and you'll get better, etc. But
yeah.
anyways, this is a great conversation. And I feel like I'm pretty good with behavior change, but my skill set has already increased a little bit. Listen to that.
I love Jeff. I love your springboard analogy for another reason too. You talked about the kind of the ladder or the steps on the ladder, being the identification of all of those skills and resources.
Yeah.
The other thing that happens as you climb up to the high springboard, if you paid attention in physics class at school, you'll know that when you're standing on top of that springboard, there's an enormous amount of potential energy,
Absolutely.
and it has the capacity now to be turned into all sorts of energy, including kinetic energy, when you actually move forward. And so there's a very real sense in which the identification of all of those skills, the naming of the resources, generates potential energy within that person, which can then be converted into other types of energy that are useful to them.
This is great.
Jeff alluded to something else in his last statement, which does lead me to my next question. In that in medicine, we do not often get to operate without an expected outcome of some kind, and it's often an expectation that we ourselves create in a situation. It's actually something even in this podcast. I think if Jeff and I were to say, we were successful in doing this podcast and supporting, the medicine to fitness bridge, that the outcome would be that there are more referrals going from medicine into fitness in some way. And I think outcomes sometimes alter our behavior. We sometimes operate for the outcome rather than the best intent of the person. I may be answering the question that I'm about to ask by even saying this, but I think it's part of the picture, right? And it's leading me to the next question, which generally speaking, it's obviously not just the outcome that leads us to do things that may actually be not good towards where we hope people can grow in the most meaningful way for themselves. But I'm curious, just generally speaking, where do you think clinicians fall short when trying to apply behavior change theories, whether it's the trains theoretical model, motivational interviewing, any of this that we've spoken about today, in real world referrals to fitness professionals? Again, if Jeff and I are going to say we're successful, we see more referrals to fitness professionals, but even just the expectation of that outcome may alter behavior in a way that is anti to doing this process right. So I'm curious, how do we do that best, and what gaps that exist today do we need to close to be more effective at getting people to the right professionals to support them?
Yeah. How long have we got?
We have 15 minutes.
Okay. So this is I think this is a really complex question, Thomas, and it takes us immediately to the system and structure level of healthcare as well, not simply the individual practitioner and individual patient level. So there's a few things that I think we can think about there that might shed some light on this. The first one is that again, I think our training, all of our training in healthcare is very siloed. So we think about phrases like staying in your lane come to mind. Scope of practice is the more formal way of talking about that, of course. And again, I want to be very clear here. Scope of practice is important. I don't want a podiatrist doing brain surgery on me, nor do I want a neurologist operating on my foot. I want the right person with the right training to do the right job. But unfortunately, I think sometimes we extend that idea of scope of practice into this real sense of silo. So what we tend to do is, chuck the ball over into the next silo, the ball being the patient in this case, and just go, okay, well, that's kind of out of my, I'll give it to you, and you do something with this. Whereas, in fact, a more helpful way of thinking about this would be to construct a model in which we are all connected to each other from the outset. We talk a lot about for example, creating multidisciplinary teams or creating interdisciplinary teams. Why don't we ever talk about creating an individual practice? Why is the multidisciplinary and the interdisciplinary team not the standard? Why is that not the norm? Why would we, why don't we think it unusual to work separated from a system rather than a really deeply integrated part of that system? Now, I have a particular view of interdisciplinary, which I'm happy to share with you, and a lot of people might disagree with me, which is absolutely fine. We're all familiar with multidisciplinary. Multidisciplinary is good because multidisciplinary means we have a dietitian and so on, and we all bring our own expertise. There's still a bit of an inclination for siloing with that. I think, for me, the true mark of an interdisciplinary team is a team of all those different professionals working together with the patient such that the patient has difficulty naming the specialty of each individual person. In other words, what the patient has is an experience of care, complete health care provided for them, if you like, holistic health care. But the individual person providing that is much less important than the experience of the whole. And I think it's that structural siloing that is one of the challenges that we need to overcome. A second one, of course, is that there's not. I think there's not a sufficient common language between practices, and this is coincidentally is actually one of my hopes for lifestyle medicine, and it's one of the reasons that I became involved in lifestyle medicine, a dozen or so years ago. I think lifestyle medicine has the capacity to move us in this interdisciplinary direction and unite healthcare professionals with a common language that we can all understand and that we can all speak to each other about and with our patients about as well. So, if from a lifestyle medicine perspective, a physician understood the true value of resistance exercise, for example, that might be a very different conversation with a patient, and it might be a whole kind of very different orientation from that physician. If dietitians understood that, if exercise physiologists, for example, understood more about diabetes, for example, if psychologists understood more about this and so on, if we could build this shared language on the basis of lifestyle medicine, then I think we have an opportunity to start breaking down some of those siloed barriers. And Jeff, I know you've done a lot of work in this area in particular, and naming very clearly to exercise professionals that the same fundamental set of principles work regardless of the individual. Yes, of course, you have to make some adaptations, and you have to begin where that person is and work with them from that point. But you don't need to come and do something completely different because a person has diabetes, or because they have knee pain, or because they have, CVI, or something like that. You can begin where that person is at with that same fundamental set of principles. And again, I think this goes back to some of the education that we all get in our primary training. That's where the hole in the system is, if you like, back at that level. And again, this is one of the reasons why I think lifestyle medicine has such potential to revolutionize our healthcare system, because we've got an opportunity with lifestyle medicine to to get these principles embedded into healthcare and medical curricula pretty early on. And this is happening. This is happening already. For example, next week I'm giving a tutorial to university students in Australia who are taking a module on diabetes, and I'm speaking about behavioural change. I recently taught a course at a university in Greece. I'll be teaching at a university in Chile, South America, later this year. All over the world now, universities are beginning to recognise in medical curricula, particularly, beginning to recognise the value of lifestyle medicine approaches. And again, going back to something that we said earlier, if we have this conversation 20 or 30 years from now, I reckon, I really hope, but I reckon we might be having a different conversation, and I think we might have seen the needle move here.
We have 5 more minutes, and I'm going to piggyback off this and ask one more question.
Sure.
Because conceptually, I understand and agree with everything you're saying, but from a practical standpoint, I'm wondering, and it's a little bit of a loaded question, but you're starting your own facility, and this is how you're going to model it. And now from a user standpoint, the patient walks in, how are they going to, what's their experience going to be like, so that they are experiencing everything and not feeling like I'm going to see a physical therapist, or maybe
I'm
the
bouncing
doctor
between.
today,
Yeah.
and then the physical therapist the next time I come in, and then Jeff, 2 weeks later, or whatever. But what I'm just trying to wrap my mind around this a little bit more from a practical standpoint. If you were starting your own facility, what would it look like? And you got about 5 minutes,
Okay.
and the user experience.
So first thing I'll say is that what I said earlier about interdisciplinary teams is highly conceptual. I don't anticipate that we could, certainly in the near future, design a system that looks exactly like that.
Yep.
But it represents a, if you like, an end point of a spectrum.
Absolutely.
For me that is kind of the ideal. The ideal user experience, if I was starting a facility, the ideal user experience for me, if I walked into that facility, would be the very first thing that someone says to me is not, "What's the matter with you?" but "What matters to you?" We begin there. We begin with, what's important to me here? What do I want for myself? What do I want for my future? Why do I want it? And then, having that discussion about strengths and values and resources and so on. And I would want that to come from all the professionals working in that facility, whether they're a physician, a dietitian, a psychologist, a health coach, an EP, it doesn't matter. I would want everyone to be united in that type of discussion with the person, and bringing their own expertise to that as and when necessary, but only in that amount. Not leading with the expertise all the time, but offering that the expertise is there, and having the patient agree to it, in a sense. The metaphor that I use here is the person standing in the shopping centre pushing a pamphlet into your hand. What do you do? You do what we all do. You just walk straight past. You don't even make eye contact. Sometimes you do a wide arc around them just so you don't have to have that experience of someone forcing a pamphlet into your hand. But if you approach a shopping centre and someone says, "Good morning, sir. I've got some information about I don't know, dog grooming or something," and you already have an interest in dog grooming, then you're much more likely to say, "Okay, yeah, I'll take that and have a look." In other words, what the person has done is not push that information to you. They've said, "I had this information. Would you like it?" And because you've already been primed by recognizing your own needs, desires, interests, and so on, you say, "Actually, yeah, I would. I'd like that information." So in many ways, it's sort of an inversion of the way that we do things now. We consult people. I mean, I call myself a consultant, so I'm as guilty. I'm as guilty as the next person. I need to point the finger back at myself as well. But instead of having this model where we create these senses that we're the consultants that people come to, kind of invert that so that the interest, the desire to understand, the desire to support and affirm starts to emanate from the opposite direction, and is initiated there.
Real quick, because Simon, what you're talking about is something that Jeff and I spend a little bit of time talking about together. And it's kind of a scandalizing word, I think, in the world of behavior change. But what you're talking about to me is a very supportive environment with an effective, and again, I know this is a scandalizing word, but with an effective sales process. That people are not pushed things that they don't need, but are offered things at the right moment that suit their needs. And
Exactly right.
I think there's a lot
Exactly
of
right.
comfort in the behavior change world sometimes to support people to find their own conclusion and say, "Okay, I've done my work,"
Yeah.
without connecting them with the most meaningful thing.
Yeah.
And the ability to do so does require, I mean, that is in a word, sales. And I'm curious how you
Yeah.
feel about me saying that word in this conversation, even in that thought process, because I think sometimes in supporting our patients, we do need to point them in a direction that is specific and not just ambiguous. So I just hear your thoughts about that.
Absolutely, we do need to do that, and that's where our subject matter expertise plays an important role. And we would be remiss in not doing that as well. But that's often our first instinct, to kind of push information or push in a particular direction, rather than pausing and asking that question: what do you need right now? What's important to you right now? Listening to that part first before we then offer the rest. And Thomas, if what you just described, if the structure and the process that you just described is scandalizing, then what I would say is, please scandalize me yesterday.
That's great.
That's great, Simon. I appreciate that. Yeah, I think it's not even so much the process that's scandalizing; it's the word that comes with the prior misconception of exactly what you just said. That to offer people something that they might benefit from comes in the absence of having the conversation to identify what they really need and how they can be supported. And I just think that misconception is what leads so many people to a place where they're ready to change but don't know what to do, and they often go and find their own solutions on YouTube or elsewhere on the internet. Right? And I just think if we are in whatever model, to your point, a multidisciplinary medical future looks like, we are going to have to be effective at managing up the people around us and supporting our clients, patients in getting to the right place at the right time based on what they tell us they need. And at some level an assessment on our end of what they might benefit from as well, right? So I really appreciate your thoughts on that.
Thanks, Thomas.
All right. Well, we need to wrap this up. So in the last couple minutes that we have, Simon, I would love if you use this an opportunity to just let the listeners know how they can connect with you, whether it's LinkedIn, website, and your pre-conference presentation at the ACLM, anything at all, and we'll also make sure that we put it in the show notes.
Yeah, sure. Thanks, Jeff. I appreciate it. Well, the pre-conference workshop, obviously, people can find on the ACLM conference website. We can put that up. If people want to reach me directly, either LinkedIn, if you happen to inhabit LinkedIn, and there's a few Simon Matthews around, but I'm the Simon Matthews who's connected to Jeff Young and Thomas Hammett. So pretty easy to find that way. And people can also reach me via my website, which is simply simonmatthewsconsulting.com. Two T's in Matthews.
All right, great. Hey, this has been an awesome conversation. I've definitely learned from it, and I really appreciate having you as a guest, Simon.
Been a pleasure. Thank you both.
This episode of the Medical Fitness Podcast is brought to you by the Medicine, Rehab, and Fitness Institute. The MRFI has been co-founded by medical, rehab, and fitness practitioners who see the medical necessity in getting people to be more active and fit. There is a sleeping giant of opportunity to building a more active population, an opportunity which lies in a more effective medical referral pathway to exercise programs and professionals equipped to serve that pathway. To learn more about our services and how we're working to make this a reality, visit mrfinstitute.org. That's mrfinstitute.org.